Great. So let's get started with a roll call and introductions. Katie, I'll hand it over to you.
Wonderful. So this morning's question, as we do roll call, is what is a piece of advice you have received in your life that has stuck with you? So roll that over a little bit, and I will start with Helen. Helen Blanca.
I'm Helen Blanca, and I would say my dad told me about when I was in high school regarding jobs and professional opportunities. He said you should always be willing to show up and wash the dishes. And it was a really great piece of advice, just being able to show up and do whatever work that needs to be done, be willing to show that you are not above any kind of service if it's toward a greater goal. And that has really served me well. I've gotten my best professional opportunities by just showing up and being willing to do whatever it was that needed to be done.
Thank you, Helen. Deborah Diaz.
Debbie Diaz, she, her pronouns. My piece of advice I will share was one that my grandmother shared with me, and she would always say, motion is lotion. Just keep moving your body while you're able.
Chun-Wei Chi has a previously scheduled engagement, so he is not able to be with us today. Amy Fellows.
Hi, Amy Fellows, she, her pronouns. I think I was raised by a basketball coach, and just his attitude was kind of like, whatever happened, it's in the past, you keep going forward. So a little bit similar to Deborah's. Thanks.
Warren George.
Warren George. I think of many good pieces of advice I've received from many people, including my father. But one that sticks with me is when we asked him what kind of car we should buy, he said, buy a Renault. The junkyards are full of them and it will be easy to get parts.
You've only owned Renault?
Thank you, Warren. Michelle Glass.
Good morning, Michelle Glass, she, her pronouns. I read a book when I was in my early 20s by Todd Getland called Letters to a Young Activist. And he said, we must be this is a paraphrase, we must be willing to commit to the fight, whether or not we see the results in our lifetime. And that really stayed with me ever since.
Thank you, Michelle. Bruce Goldberg.
Bruce Goldberg, he, him pronouns. Best advice I ever got was smile.
Thank you, Bruce. Cheryl also has a previously scheduled engagement, so she will not be with us today. But Judy Richardson.
Good morning, everyone. I think the best advice I received was be nice to everyone. The worst that can happen is you'll accidentally be nice to someone you're mad at.
Perfect. Thank you all.
Great. So on behalf of the board, I want to recognize and thank those who are taking time to communicate with us about our work through public comment. Since the last board meeting, we've received written public comment from Mr. Charlie Swanson, who was on the task force. He provided some comments on our preliminary structure for the plan, especially regarding incorporating Medicare into the universal health plan, and that will come up again when we're in that section of our agenda. We'll talk about his comments there. Thank you for those. And then Dr. Samuel Metz submitted a letter that was from the Physicians for a National Health Program that was originally written to Governor Kotek and our legislative leaders about their recommendations for the structure of the plan. So that's relevant for our discussion as well. And then Mr. Tom Sinsick advised us to carefully consider whether our budget was sufficient for our work and to request more money if it wasn't. We really appreciate those comments. We definitely take them into consideration. And you'll see today in our values and principles discussion, the previous written testimony has been incorporated now into our work. So thank you for taking the time to reach out to us. In addition to official written testimony, the board has received multiple emails regarding our work and asking for an assurance of transparency in the work that we're doing. Of course, all of our meetings are public and all of our documents are available for public review because we are subject to public meetings laws, and Morgan has been excellent at keeping us on task with that. So we are very committed to transparency in that. Per our policies, there are no meetings of a quorum of the board that are not noticed on our website and open to the public. And the board members read all of the emails that are sent to us. And then per our policies, Director Cowling is responding to them. Just as a reminder, the best way to engage with the board is through our official written or oral testimony process. The directions for that are on our website, and we encourage anyone who wants to engage with us on our work to use that channel as well. Okay, quick agenda review. Today's meeting is going to be pretty discussion heavy. We're going to hear a presentation first from Jenny about various financial models for the plan that we can consider. And if we like, we can discuss whether or not to establish a work group of the board to give a recommendation on the structure we should use. We're going to get an update. After that, we're going to be discussing and reviewing and approving the values and principles. This is our third time with that effort. So we're going to hopefully be able to approve those today. And then we're going to spend some time discussing the preliminary structure of the universal health plan. And if we're ready, we can approve that as well. We're going to get an update on recruitment for the committees and then the next steps to engage other members on our committees. And at the end of the meeting, we'll be discussing the timeline and process for our status report to the legislature, which is coming soon, which is December. So as I mentioned, this is a pretty discussion heavy meeting. We're going to make our best attempt to stay on time for each topic. I'm going to ask for all your cooperation with that. So I've asked Katie to give me and Warren a quick warning when we need to call discussions to an end. Of course, there are going to be some parts in our agenda where we really need to keep the discussion going because we need to come to a resolution or a conclusion about it, and we'll consider that as well. But that, of course, means that we might have to cut other items short. So I'll ask for all your help on that. So now we need to approve the minutes. Has everyone has had a chance to look at the minutes? Does anyone have any questions, comments, corrections?
I move to approve the minutes.
Second.
Any discussion? Okay, Katie, can you do roll call?
Helen Blawonka,
Yes.
Debbie Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
and Judy Richardson.
Yes.
Excellent. Okay, so now we're moving on to the executive director's report. I'll turn it over to Morgan to give an update. And I would ask that everyone please hold your questions until Morgan has finished her report, and she'll invite questions at the end.
Thanks, Helen. And thank you for the opportunity to just share a couple of areas where the staff has been focused in supporting the board's work in between the meetings. The biggest bulk of our work really has been in kind of committee recruitment, committee application review, and we have a special agenda item to talk about that in more depth. But I just need to say that that's been such a huge undertaking, doing the outreach and engagement and meetings and emails and I look forward to talking with the board more about that on this agenda. The other piece that we talked about at the last board meeting was bringing on additional capacity to support the board's work, support the committees. And two big buckets that we're working on. We're continuing to work with OHA on hiring the 2 limited duration positions that will be at OHA to support the board's work and ensure that there's good connection between our staff at DCBS and OHA. And Jenny and I are participating in those interviews, and we're still looking at a timeline of bringing those positions on in early fall. The other piece is bringing on contractor support. I think I shared the last board meeting that we're working to access OHA's technical assistance bank. Though that contractor will be focused on providing technical assistance and strategic guidance to the committees, including assisting in the preparation of the final report, the status report that we'll be talking about later. So we are working to finalize that statement of work and finalize the interagency agreement between DCBS and OHA. So I will be excited to announce that pretty quickly, and we're hoping to have a start date of September 1. The other piece is the release of a large RFP. I outlined those steps in that process, and I'm happy to share that after the last board meeting, DCBS released the paperwork for the submitted to the Department of Administrative Services, the paperwork for the delegation to DCBS to manage and execute that RFP. While that process is happening, we also worked with them to release a request for information so that we can get information from potential contractors about things we may want to consider as we develop that scope of work. I've also met with our Department of Justice attorney who will be reviewing the statement of work. So I'm trying to get as many things going to front load that work while we're waiting to get the delegation from the Department of Administrative Services so that we'll be able to move very quickly. And with that, I'm happy to answer any questions.
No questions? Great, thank you, Morgan. Okay, so at our last board meeting, we agreed to add an element to phase 1 of our work plan, which is the phase we're in now, trying to get our background information and get everyone up to speed. And that element was to review different financing models for universal health plan. So Jenny's going to do a presentation on various financing models that we could base our plan on. And there'll be an opportunity for some discussion and some questions. At the end of it, we're going to have an opportunity as a board to decide whether or not a work group would be appropriate for us to dig down deeper into these models and decide on the best recommendation. So please consider that as you're listening to the presentation, if you'd be interested in creating and serving on the work group. Thanks, Jenny.
Thank you, Helen. Okay, as Helen said, this is followed from the last board meeting where the board had requested looking at some financing models. And so today I will cover 4 basic healthcare and financing models. We'll look at defining the term single payer. We'll look at how the term single payer is defined in Senate Bill 1089. And then we'll look at how the 4 basic models interact with single payer and multi-payer models. And then we'll talk a little bit about unified financing, which is a new term that's sort of coming in vogue in universal healthcare. And then, as Helen said, I'll have some time for some questions, but really more discussion about whether or not they would like to propose a motion to set up a work group. And so, looking at the 4 basic healthcare and financing models that are out there, there are 4 models that primarily are discussed: the Beveridge model, the National Health Insurance model, the Bismarck model, and the fee-for-service model. So the Beveridge model is what is commonly discussed in England, and it's the National Health Service model. This is a model wherein the government collects taxes. In the England model, the UK model, it's a general tax fund. So the government collects the taxes, and then the government also owns and operates the hospitals, clinics, and employs the providers. This is a true single payer model. This is a model where the government really controls and regulates all facets of the healthcare industry. However, in this model, there is also still room for private insurance. Private insurance is something that you pay extra for that can cover services that maybe aren't in the national model, or for certain perks that you may want that aren't provided by the national model, such as faster care time or possibly a private room. Other countries such as Spain, New Zealand, and Cuba also have the Beveridge model or the National Health Service model.
Jenny, can I just interrupt for 1 second?
Absolutely.
I'm just a little confused about how we're using the term financing. Because it seems you're talking about 2 different aspects of financing. One is how you pay providers for the care. The other is how you actually pay for the entire system.
Yes,
Okay.
and so to give a little bit of. So in terms of looking at the financing models, it is generally within the system models that you'll see that financing and how providers are paid are sort of considered within the systems together when you're looking at the basic models and how they were developed. Financing generally comes from either the government taking in taxes in either payroll taxes or looking at it through general taxation, and then financing how the system is delivered. And usually in looking at these models, how the system is delivered is also incorporated into how the term financing, if not the actual practice of financing, is delivered. When we get to Senate Bill 1089, we'll look at the idea of a single payer system and how single payer was defined within Senate Bill 1089. And there, it defines single payer as the government pay or another entity paying, but also discusses how providers would be paid by that system. And so often we find in financing that if we're talking about how finances are collected, we also then discuss how they'll be paid out as part of that system. Though they're not the same, obviously, they're often put together in terms of how the discussion moves along in terms of healthcare financing systems.
But we're talking about both then, not one aspect, not how care will get paid for in finance or how the system will get financed.
Sort of, yes,
Okay,
and how the system would get financed and often how it would then be, how the payer would be, or I'm sorry, how the provider would be paid.
my
outside
sense is
that
they're
system.
two very distinct things, and we just have to be careful which one we're talking about. Okay,
And so in looking at these, of the four models, it's usually looking at how income is collected or how the finances are collected, whether it be from a government model where the government is collecting all the taxes, or whether it's creating a fund, or whether there's no pooling of resources at all. And so looking at the national health insurance model, again, you have the government collecting all of the funding. And in Canada, this is funded through government taxation or through contributions. And these are sometimes small copays. The government in both of these systems very much regulates how costs and services are delivered. And so with the funding model coming through the government and government regulation overseeing the cost and services, you look at how much funding needs to be collected. In the Bismarck model, you have what is called social insurance, and this is the model that was popularized in Germany, hence its name. And in this system, it is employer and employee contributions that actually fund the system, primarily coming into what are called sick funds that are then used to pay out individual insurance groups that are usually identified by occupation. There is also contribution that comes from those who are not employed or those who are self-employed and are not paying into these funds. So that the idea is a socialized service where everyone receives healthcare, so a universal health model, but with multi-payers from different insurance funds paying for services for different types of occupations or for those who are unable to work or do not work. In this system, the providers are paid by the insurance fund, but the government still has a role in regulating the costs and fees for service. And finally, there's the fee for service model, which really doesn't comprise a model. It's a model where all of the providers are private, all of the people in the system pay at the destination for whatever services they get. There's no insurance inherently part of this model. If you're looking at the United States, we have sort of a combination of all of these different models. We have insurance funds where we have employer and employee contributions. We have funds through Medicare and Medicaid where the government is helping pay for some of those services and the government's collecting general taxes. But we don't have one of these models fully encompassed in what we provide. And looking, go ahead, Helen.
So like just distinguishing among the four types, can you go back a couple slides, please? So the beverage model has like sort of the state is collecting, so there's money coming in, there's money going out, right? And so in the beverage model, the money coming in and the money going out are both controlled at the state level. In the national health insurance model, money coming in is all goes to one pool at the state, but how it goes out is more in the private system.
It also, so not federal government in Canada, the government in Canada collects the money. Some of that money is then paid out to provinces for different services, and so it's still centralized within the government, but the providers are private. And how they're paid is still through government collected funds. It's just the providers are private in the national insurance model, whereas in the national health service model, the providers are also paid by the government. I'm sorry, employed by the government.
Yeah, right. And that difference from social insurance and social insurance, the Bismarck model, the money is pooled into private, right? It's not pooled at the state. The money is pooled into private organizations, private companies, and they can't make a profit. So the government level of involvement is just saying everybody has to be covered, and employers have to participate, that kind of thing. And so it really is more of a coverage model, but where the money is collected is in the private sector,
Yes.
as opposed to like in a state.
And the government still has a hand in regulating the fees and regulating the industries and ensuring that there's no profits made by those sickness funds or the funds that are collected by these employer-based groups.
Right, so really is kind of assuring universal access to care
Absolutely.
without getting involved in how the money is collected or how it's paid out.
And they kind of call it the one for all model that's how it's talked about in Germany, and ensuring that everyone has healthcare coverage despite how they're paying in or their ability to pay it.
Great, thank you. Oh, and there's a question from Amy.
Hi, and you might get into this further in the presentation, so I can wait if that's the case, but I'm just having a hard time kind of translating these national models into what that looks like in a state-based model where the rest of the country's doing something different. And I was wondering, are you going to get into how any states that are further ahead of us, like what their models translate into?
I'm
makes
gonna
sense.
talk a little bit about that, Amy. It's not one for one really, because at the state level, it can be so much different. But I am gonna talk a little bit about how states that are working on the same projects that we're working on here in Oregon, primarily Washington and California, are looking at financing as well. And it sort of takes a step outside even these four models.
Yeah, it seems like it's more complex than would have to. Yeah, thanks.
Thanks, Amy. Okay, and so looking at single payer, and so all of the four basic models are defined by who's collecting the money, how the money is being paid out. None of them are defined by saying this is the single payer system. Though you can look at something like the beverage model or looking at the national health insurance model and say these are single payer systems. The government's collecting the funding and then the government is paying that funding out. Looking at Canada, they do have the government, the centralized government collecting the funding and then paying out to provinces. I would say that was still single payer in most literature and things that I've read, that's still considered single payer because it's still the government in its entity paying out for services, even though it's not centralized to one centralized government. The provinces have some say over how that funding is put out. In terms of single payer, from what I read about, the term was coined in the 1990s when the United States started talking a lot about Canada's national insurance model. There was a lot of rhetoric around it that started to call it a socialized medicine model. That didn't go well with Americans who were at the time very much against the idea of socialized medicine. And so the term single payer became more and more popular. In the last 25, 35 years, the term single payer has become sort of ubiquitous with universal health care. And in an article that was written by Jody Liu and Robert Brooke called What is Single Payer Healthcare? A Review of Definitions and Proposals in the US, which is in our resources, they describe and look at 25 different instances of single payer in the United States. Different legislation, different journal articles, and definitions that have been used to describe single payer. And what they found is it's heterogeneous. It has commonalities and they're all called single payer, but what's actually delivered within those systems is not necessarily always the same. There are differences in how payers are anticipated to be paid. And this, even though with exactly what Bruce was saying, how the money is taken in, the idea remains the same in terms of single payer. One centralized body would take in all the funding and then pay out. But the idea of single payer has started to encompass multiple different ways for, even though that money's being pooled together, the way that it's being paid out and the way that they're looking at the idea of what single payer as a term means really is starting to be universal healthcare rather than just a single payer. And in looking at it, it's easier to define single payer by what it isn't now than what it actually is, in that it's not always a government entity. It could be a private organization or a public organization that actually pays out those funds. It doesn't necessarily mean universal healthcare, though often in proposals, it does have the idea and the goal of universal healthcare. And it never mandates a specific delivery system. The delivery systems are all over the board in terms of how providers are going to be paid and how care is going to be delivered. Lucky for us, Senate Bill 1089 actually defined the term single payer as it could be used by the board. And in the definition for single payer, it doesn't say in Senate Bill 1089 that the board has to take up a single payer system. But it does say if the board takes up a single payer system, this is how the board will define single payer. In the single payer system defined by 1089, it means a universal system by the state to pay the cost of healthcare services and goods in which institutional providers are paid directly for healthcare services or goods by the state or by an administrator that doesn't bear the risk. And so doesn't have to be the state directly paying those funds. We can have an administrative unit. And then it goes on to discuss how institutional providers are paid, how group practices are paid, and how individual care providers are paid. And so making synonymous again, the idea that we're collecting funding, but how the payers are paid, or I'm sorry, how the providers are paid is inherent in the definition here. When we look at different single payer models around the world, we can look at Canada, we can look at the UK, and we can look at Taiwan. I do feel a little bit sad that Chun Wei isn't here for this particular presentation to discuss Taiwan, seeing how he was one of the architects. But in these systems, we have a single payer, but there are differences within the systems. Canada delivers funding out to the provinces to help pay, and the providers are private. In the UK, the government takes in all of the funding and pays and employs all of the providers. In Taiwan, they have a payroll-based system to collect some of the taxes, where in Canada or the UK, you see a more centralized government tax. And in Taiwan, you have private providers and some public hospitals. Also, you have a mix of whether the providers are going to be state-based or whether they're going to be privately based. Looking at multi-payer models, you then look at the Bismarck model, where you have a centralized idea of government, you have government oversight and regulation, but you're still seeing the funding being collected at the employer level. You're having funds taken in by employers and then contributions in addition to those funds taken in by employers to ensure that there's universal coverage for the population, even if the taxation system is primarily looking at and those employed and how the employers take in that funding. Usually in those models, you also see nonprofits and some sort of prohibition on those companies, those fund collectors making any sort of profit from the system. And you will still see heavy government regulation of the pricing systems and the cost systems. Excuse me. And this is a little bit to Amy's question. What are we seeing in the United States, since most of the work around universal care is at the state-based level? Something interesting that's come about at the state-based level in California and in Washington is the idea of unified financing. In both the California legislation to work on the universal care model and in the Washington legislation to work on a universal care model, they mandate that the groups looking at this look at a model of unified financing. They don't say single payer, multi-payer, and they don't identify a different model. They call it unified financing. The idea, from what I've been told by some of the supporters of this legislation, is that it's to step away from the term single payer and sort of the connotations that that's developed over the years, but to also look at the system in terms of pooling resources together, looking at how there have been numerous debates about whether or not Medicare could be brought on board for a universal system or for a single payer system. But looking at really what are the sources of funding that we could look at and how can we pull all of those together into a large enough pool to start delivering universal care. The term hasn't been defined yet by California or by Washington in any of their documents or their legislation, but it mandates that they look at this new term, unified financing, as a financing model. Washington has set up a task force to look at financing. California has a report coming from UCLA on how to look at financing in their entire program. And so it'll be interesting as we move through our work to look at our neighboring state to see what they're doing in terms of what unified financing might come to mean. So we have some resources. I'm happy to take any questions, or we can move into the board discussion for the motion. What you'd like to do.
Go ahead, Lynn.
You identify fee for service as one of the four systems. I liked Bruce's earlier comment. We've got kind of two sides of the equation, raising the money and paying out the money. And I guess I'm used to thinking of fee for service as just one side of that equation. So it would be fee for service or global budgets or capitation. Anyway, I wondered if you had any why you included it as a separate one. I think some people would argue it's on one side and the others are kind of on the other.
Sure, and that's, I think, due to where I'm at in my understanding and learning of healthcare financing and healthcare systems. If you look broadly at what healthcare systems are, they're generally defined as these four basic models. I'm guessing that this is some sort of like 101 level understanding of healthcare delivery. But in looking at most of the literature around it, they'll define four primary systems, and the four primary systems that are identified are consistently the Beveridge model, the Bismarck model, national health insurance, and then fee for service as just the final model, which in my understanding and looking at this, it doesn't seem like fee for service is an actual model. It's just sort of what happens when there is no model. You have a lot of people just paying directly for service. They mentioned in some of the literature provinces in India where there isn't a health service system, and you're looking at that fee for service as a model where individuals are just trying to go and get care with whatever they can pay.
So,
And go ahead.
so it's more like direct pay
Exactly.
would be in this case.
Not within a system where you have pooling of funds and then if there's any sort of like fee for service at the site, you're just paying, where in some of like the Bismarck model or the Beveridge model, you could still have at the site someone paying directly, or you could have fee for service in the model from the national model. But looking at fee for service and how it's described here, it's really where there is no universal system. There is no actual system surrounding it where individuals are just trying to go to private providers and paying out of pocket for care.
So I don't think it's always kind of just a direct pay model, because we have evidence of Medicare and both Medicaid functioning as a fee for service model where there are central pools in state Medicaid, and then providers bill and they get paid fee for service, right? And so it is a way of sort of, I mean, it's a segment of our healthcare system, of course, but there's a segment of Medicare and a segment of Medicaid that operate under a fee for service model where the money coming in is pooled. And then it's just paid out fee for service. So that's kind of another way to do it. We have there are many segments in our current system that operate. I mean, we have the VA system, we have the IHS system, we have Medicaid who's tried various different models of how to take money in and pay money out, right? And so like we have a bit of a patchwork going on now. But, yeah, but fee for service is one way to do it, where you could, as a state, have a trust fund collect all of the money coming in and then just pay out fee for service and let the provider community sort of decide how they will manage that, yeah.
Another question, Jenny, you mentioned in some of these models there's a lot of work going into well, the question profit, for profit or nonprofit. And in the United States, there is about as much criticism directed as not at nonprofits. Who can retain large reserves for, as there is for profits, and you're reading, you see what kind of distinction that is, or how effective those are in other countries.
So I didn't get to that level of looking at whether or not the for-profit or not-for-profit delivery systems or fund pooling systems, how they were regarded or how well they were doing. Most of the information that I saw was about whether or not the system as a whole was delivering adequate services, quality services, and timely services. Whereas in some of the models, care can take quite a long time, which is a pretty consistent criticism of the Canadian model, or I shouldn't say the model, the care system in Canada and in the UK have both faced a lot of criticism about wait times. And I have read literature that says wait times are actually built into some of the systems to ensure that the care that's being provided is the care that's needed, and that there isn't overutilization of the systems. And I think that that's, that's a question for how the entire plan is designed to determine how the board feels about that in terms of quality of care and timely delivery of care. But in terms of whether or not a nonprofit is effective and running well, and whether or not, there's general approval of how those systems that are governed primarily by nonprofits, whether or not those are effective or being run properly, isn't something that I came across. I'm sure there's more information out there, but it's not something that I delved into now.
Yeah, so thanks, Jenny. Lot of great information in there. Not actually, I think more maybe a question for Helen and Warren. Because, this is, this is sort of advertised as, do we establish a work group? And I guess I'm confused about what that work group would do. Because it seems to me, we've got two work streams. One is the financing, the financing work stream, which to me is, I thought the charge was to look at how the entire system is financed, i.e. the revenue coming in, the dollars in. So that's the work stream, that the financing group is going to do. And then my understanding is we have a plan design work stream. And that work stream is charged with how we pay the money out. How we deal with paying providers and dealing with expenditures. So I'm confused if we have those two work streams, what a financing work group would do. We have to figure out the revenue side, and we have to figure out how the expenditures will happen. Forgetting about models and all of that. Those are the two big tasks.
I agree.
Okay.
So my question is, why do we need a work group?
We don't necessarily, I will just clarify that part of this, and I'm gonna hand it to Warren to kind of explain further, but part of what we're doing here is considering these models and seeing if there is any concern or question about the direction we would go with our plan, and if there is, do we need a work group? It's not clear that we do, but the purpose of this discussion is to see if people need to get more information on some of these models in order to determine our financing. So it's not, we can decide not to have a work group, that's where we get to, but I'll let Warren take it.
Yes, the rationale for this is, there is some things to be kind of pre-considered. We've talked about, are we gonna try to put Medicare in or not? Are we looking at a full single payer? Are we looking at a multi-payer system? Are we looking at regulation of insurance? Because we can achieve some of the simplification. And Senate Bill 1089 is a very wide road. It gives us very little guardrail in that. And as the committees begin thinking about how wide the path are we going to take, I believe that this is a good way that we can not make a decision, but help gather information that the committees can use, pros and cons of what are the advantages of a full single payer system? What are the advantages or what are the pros and cons of only addressing private insurance? And I think if we can spend just a little bit of time thinking about those pros and cons, and coming back to the board with that would be a good use of time, if nothing else, to rule out a few things. Or as we're going forward and looking at contracts, what are we going to begin telling those contractors? Are we, it's not completely different than the task force. We had to make some assumptions about is the VA in or the VA out and some of those things. So I see this as a way to kind of get us headed in the same direction, or even we might decide multiple directions because there might be a couple of directions. So I see this as an opportunity for the board to kind of talk about that.
Yeah, well, important, I mean, I think those are really important key questions. I guess I thought those were gonna happen
Yeah.
at the committees, not, and
Right.
then bring it back to the board. But
And a concern of mine is, the committees will have some, recommendations about those after some length of time. But we all need, I think, to have some kind of understanding, and I think the public too is saying, what are we doing? Are we gonna do a single payer system? Are we gonna, do insurance regulation? And I think being able to explain to them, we kind of know where we're headed, I think is a good thing to have under our belt early. And we can change our mind as we go, but just kind of identifying the pros and cons.
In terms of the models Jenny presented, I mean, it's pretty clear that, the National Health Service model is not something that would exist, like the government's not gonna take over the healthcare system in that way. The National Health Insurance model seems to fit most with what we're talking about, where it's like a state-based insurance model. Fee for service seems unlikely, the Bismarck model where there's, a lot of different groups paying for care seems to go against what 1089 is asking us to do. And so according to what's in 1089, it seems like where we're aiming is more the National Health Insurance model. Am I off base on that? Does anyone have any other thoughts on, in terms of the 4 models that Jenny presented?
you have to scroll back to it.
Yeah. Right, so beverage being, but in the beverage model, the government employs all the healthcare providers, right? So we're not doing that. That seems pretty obvious. The National Health Insurance model is more pooling the money at a government level, which in our case would be the state. And then the providers all remain private, and the state trust fund would be the primary payer. Bismarck model is a multi-payer system, but there's no sort of centralized pooling of funds, which is what 1089 is asking us to do. And fee for service, as Jenny said, isn't really.
Yeah, no, I agree.
Yeah,
But the issue is,
Right,
under all of those are some,
exactly.
there's a whole host of questions. When you say payment, what does that mean? Is there
Exactly.
risk? Is there capitation?
That's right.
Is there global budgets? Are you paying fee for service? I think you're right. We're not gonna
Yeah,
have government employed healthcare providers.
right.
But I mean, that's on the payment side,
That's
and
right.
on the revenue side. Yeah, there's gonna be it's gonna come to one place, but we need to have some discussion about where that comes from.
Right,
Income, payroll, sales,
that's right.
something else. Those are all,
Exactly.
and that's what I thought.
That's right. I
We're-
agree with you. I'm agreeing. Yeah, so in terms of that's not what the work group would be discussing. It's those 4 models, I guess was my point. the idea is we kind of are aligned, unless anybody disagrees, please chime in, but we're kind of aligned under this national health insurance model. And the discussion comes with what Warren is saying and what Bruce is saying about like, what is in and what is out? Can we incorporate Medicare? And if so, what are the ways we could do it? How do we engage employers? Like all of those kind of questions. And then dealing with risk and capitation, and if there's third-party administrators or not, or, you know, where is the risk borne in the system and how do you account for regional differences? Those are the things that need to work out. I'm not sure, so if we were to create a work group, it would be only board members, it wouldn't involve external folks, although of course we could consult people and use resources if we need to, but it would be just a small group of the board to sort of give a little bit more direction on that and answer some of the questions that Warren raised about, you know, how we come up with that. Or we could decide to say, you know, as Bruce said earlier, like the financing committee's just gotta work out, you know, where the finances can feasibly come from, what's feasible. The plan design and expenditures committee, their job is to decide how providers will get paid, how the risk will be shared, if at all, with providers, how money is gonna go out. So in the committee structure, finance is how the money's gonna come into the plan design and expenditures, how the money's gonna go out. There are a lot of options in there and a lot of things to consider, and as we're about to launch those committees, we could decide to just let the committees sort of sort through those details. I think Warren was proposing that before we tackle that with the committees, does the board want to come to some sort of clarity on what we think should happen regarding that? So that's what I'd like to hear from the other board members about, is if we feel like we need a work group for the board to come to some sort of clarity or just assign it to committees.
I'll turn in.
Yeah.
I mean, my sense is there are a lot of really important questions that it would take a little while to work through.
Yeah.
And it would likely delay the work of the committees. It seems to me, I mean, I'd be in favor of letting that work happen at the committee level. I'd be in favor of letting that happen at the committee level, although I'd go along with whatever decision the group makes. Having said that, I think the use of the board time would be really well spent in terms of greatly defining the charges to those two committees.
Yes.
And really being clear on what we want to see back from those groups, so that
Yeah.
rather than answering the questions, I think what the board could do is clarify the questions and clarify the issues and be able, so we're certain that then they come back with recommendations about the kinds of things we were expecting.
Yeah.
But I'm happy either way.
Amy?
Yeah, I agree with Bruce, and as someone who sits on multiple state committees, I don't want to disempower our committee before it even begins. Because I, as somebody that's been on committees, have experienced how that feels. And so I agree that us having clear guidelines on the purpose and charge of the committees is our role, and then we should let them do the work and bring it back to us.
They may not be able to agree, and it may still be up to us.
Yeah. Any other board members have thoughts on whether this is a new work group or just allocated to the committees? So, let's do a fist of five, about, so right now, sort of what we've heard so far is, that this work needs a separate, so there should be a work group to delve into financial models. So whether or not you agree with the statement, there should be a new work group to delve into financial models, and clarify the questions that we're gonna be asking the committees, about the work we're asking them to do. I'll preface this by saying we are doing a lot of sort of direction to the committees, and we'll get to that later in our agenda. We are doing some direction there. And we can add to that, as we're going. The question is, do we need a new work group to kind of delve into this more? Or should we just focus on giving the committees as clear direction as we can? So if you are in favor, so raise your hand about, fist of 5 with, should we create a new work group of the board members only to kind of delve into this further before allocating it to the committees?
And if I would be allowed to clarify
Yeah.
that, it would be a work group. I mean, our work groups have short duration and defined tasks. So this would be a work group that would give the preliminary discussion at the September at our next board meeting. And if it continued from there, some sort of final or additional thoughts in October. This would not be a long term.
Would be
This is a very short term.
2 to 3 meetings between now and our September meeting, whose purpose would be to kind of clarify some of the issues around the financial structure. Let's do a fist of 5. So I'm gonna look on screen first. We got Judy is 1, Amy is blocked with a fist, and Michelle is a 2. Bruce is a 2, Warren's a 5, I'm a 3, and Debbie's a 1. So feels like not a work group.
And yeah, I'm not hearing a motion.
Yeah.
So I think we can dispense with that.
Okay, but yes, okay, so we'll move on, and then we will take a lot of consideration from Warren and what Bruce said into account when we're giving our charge to the committee, so. Great. So next, we are going to be looking at our final version of the values and principles from the work group. This is our 3rd meeting discussing the values and principles for the Universal Health Plan. Since the last board meeting, they reviewed the changes suggested in public comment and have incorporated it into a structure. Michelle is going to be presenting the changes since the last board meeting, so I'm going to hand it over to Michelle.
Thanks, Helen. And also I want to extend thanks to our facilitator, Warren, and our excellent values and principles work group that has met and done a lot of really thoughtful work. I've enjoyed that work group's deliberations. So I'm Michelle Glass. I'm a member of the work group. I invite my fellow work group members to add anything that I might miss today. But we're really coming back to you, as Helen said, with to my mind, three main changes since the last time that this was presented. And I think I got this job today because at the last meeting, Warren was all prepared to present to you, and I threw a wrench in it. So thank you, Warren, for grace and for that extra meeting. I really appreciate the opportunity to consider the public comment that was submitted. So the 3 changes since the last time we talked about this with the full board, with kind of substantially had the opportunity to have a full discussion, is we took your guidance, your request for further definition, and we did some of that work. And so I hope that you see that reflected, maybe not necessarily in the slides, which is a high level overview, but in that 5.1 agenda item attachment. So there are some supporting statements and some further definition. After we had done that work and we were ready to present to you last month, we had received some substantive public comment that we wanted to take some time to consider. So we did add that. And then we, as part of that discussion, we did make one third change, which was initially when we came to you, we had the health equity statement as a separate statement, and that has been incorporated into a more streamlined structure with the other 4 overarching principles. But I do want to emphasize that the work group would unanimously agreed that we want to really emphasize that comes first for a reason. And that's because we see that as the overarching guiding principle for all of our work, including, I would say, the work of this this work group. We really took that health equity definition as guiding our work in fleshing out the overarching principles and values for this work. So those are kind of, in a nutshell, those are the three things that have changed since we presented to you the last time when you asked for more definition. So we have 5 overarching principles now. The first one is health equity, and that is that health equity statement from the Health Equity Committee, which is a subcommittee of the Oregon Health Policy Board. The second one is maximizing health. The third one is fair distribution of medical resources. The fourth one is minimize the financial hardship from medical bills on individuals and families. And the fifth one is community sense of ownership and governance. And as you can see, there are some supporting statements here, and there's even more detail in the full document. So again, I encourage you to look to that as guidance as we move forward, especially in our committee work. Each word has been weighed and discussed, and so these words are chosen very deliberately. And then the other thing that I would say is that there was substance and there was structure. And so, where we landed was a structure that we hope will be useful and actionable so that it's easy to read and really have this in front of us as we move into our work group work and our full board work. So we're hoping this will be something that is actively utilized by each of us as a board member. And so that's really the purpose. This isn't something that we're hoping will be a statement that we vote on today and then leave on a dusty shelf. We really hope that this will be actionable for each of us. So in addition to the overarching principles and values, which meet all of the requirements of Senate Bill 1089, as well as some additional things that we wanted to emphasize, we discussed at length 2 additional resources that we respectfully submit to you all as considerations. We didn't make them guiding valuables or guiding principles or values, but we did want to bring them forward today. And one of them was our shared commitment to meaningful public participation, and some further thought and definition to what community engagement could look like. So we want it to be inclusive of all people, provide the community details on background and current thinking related to what we're working on at any given time. We want to be able to present community members with asks, prompts, right? So that we can get substantive feedback, which we have been receiving, and I'm so grateful, so that we can consider that feedback when we're making decisions. And we want to use community feedback as guiding the perspective in defining terms and decision making. So those were some fleshed out thoughts that we wanted to bring forward that we think support our values and principles. And then another framework that was really useful for us in thinking about our approach to this work that Amy brought forward, so thank you, Amy, was the idea of targeted universalism. When we think about our charge of serving the entire state, as well as our commitment to health equity and improving health equity for all people and reducing health disparities, targeted universalism is a really helpful framework in terms of how we make that actionable. And so we have universal goals that lift up all people and improve health and well-being across the state, as well as targeted strategies that help us achieve those goals by reducing health disparities that get in the way of that. So we bring these forward as considerations in addition to the values and principles that we developed. And I again invite Warren, Amy, all the members of the work group to join me in sharing anything that you think is important that I might have missed, and I also welcome questions.
Thank you, Michelle, and I appreciate your stepping in and doing an excellent job on presenting our joint work. I did want to bring out one point when we're talking about the citizen involvement or community involvement. Really an emphasis of that is there's lots of situations where the word fairness is hard to define. And so this is, we're looking at ways, and Chen Wei-Chi did an excellent job of talking about things that are used elsewhere under the name sometimes citizen juries or other techniques where the public actually helps to set priorities or policies. So I mean, it's really we don't necessarily define fairness. We're looking to community to define fairness. And I think that's part of the spirit of what we're recommending here.
Amy has a question.
I have a comment as part of the group member, just to add on to what Warren said. I mean, I think the idea of and why I shared the targeted universalism information is to make sure that as we do this and as we think about things in terms of the greater good, that we do it deliberately so that we are not sacrificing our most vulnerable, for lack of a better words, that we are very intentional about our most vulnerable Oregonians, and thinking in particularly about those who, when we talk about health equity and health disparities, historically and currently are still, being harmed by our systems.
Thank you, Warren, and thank you, Amy. And Deborah, did you have anything you wanted to add? I know that Chen Wei-Chi can't be here.
No, I just want to thank everyone for their work on this and our thoughtful discussions over, the extension in our work group. And yeah, I'm pleased with what the ultimate outcome was.
I have a question. Do the members of the work group have any thoughts on how we will know if we are doing it well? How will we know if we are engaging the public in a meaningful way and, trying to incorporate targeted universalism? How will we know that we're doing that well? Is there any feedback that we would get on that, or any direction?
I mean, I think one thought that I have is, are people engaged in our work? Are people continuing to submit public feedback? Are people applying to join the work groups? Are people, it seems like if we're not being responsive to public engagement, that will drop off. And I've been encouraged to see the robust participation that we've had so far. I'm so grateful to everyone on this call today, to the folks who've been submitting public comment. Tom, your comment related to the values and principles was really helpful. And so I will be watching to see if that grows and it is sustained, or whether it starts to drop off. And I would take that as a warning sign personally, because I think if people feel like they're being heard, they're going to continue to give us feedback. And I think that as long as we're providing those opportunities and seeing that feedback, that to me seems like we're on the right track. I think in terms of targeted universalism, part of that's going to be, in my mind, again, what our work group composition, subcommittee composition looks like. That's something that was in strongly a strong theme in the feedback that the task force received through their public engagement, was that people really wanted to see themselves reflected. They wanted to see geographic diversity, income diversity, race and ethnicity, gender, like all the types of Oregonians that are going to benefit from this need to be part of the process. So I'll be watching that. And then in terms of some of this is long-term. And so we're going to have to keep asking this question, because how do we build a system that closes health disparities? To me is one of the biggest questions, because that's something our current system has not done well, in my opinion.
Amy?
Yeah, I would just add onto what Michelle said, like in some specific areas, we do have examples, but again, it kind of brings up Tom's point of potentially needing more funding or more robust support to really get community engagement from people who often are left behind. An example is both Cheryl Ramirez and I sit on the Behavioral Health Crisis System Advisory Committee. I think that's the right letters, but and we have a member who is monolingual Spanish speaking, and OHA is accommodating them. There's a Spanish interpreter. We can set our Zoom settings so that we hear real time, you know, what they're contributing to the conversation. Also, in doing outreach for the committees, I reached out to the Oregon Self Advocate Coalition, and they asked very specific questions about like how committee members would be supported. Committee members potentially that have intellectual and developmental disabilities. If we really want to hear from these communities, we will need to step up our game in how we support hearing from them. And so I think that's like a further conversation and something Michelle and I, especially in our community engagement committee, will need to dig into, but it will take extra support and funding to do it well and do it right. And I am committed to doing that.
Chris? Yeah. I just want to thank all the members of the committee. I think this is great.
Yeah.
And really strong work. So fantastic. I love the addition of targeted universalism. I think that was right on. When I read it last night, I was going to suggest one addition, but I see it's in there. You know, it's about the efficient use of healthcare dollars, which I think is great. I think I would have liked to have seen something a little stronger about saving dollars, because every time we spend dollars in healthcare that really are of little benefit and are wasteful, which about 30% of healthcare spending is wasteful and inefficient. Those are dollars that get sucked away from other important social endeavors, education and other things. And I think there's got to be a strong notion of stewardship and making an efficient use of dollars. So I was glad I missed that last night. I see it in there today. Thank you. This is great work.
Thanks, Bruce. And I will say that's something that we discussed. And part of the consideration, and hopefully you see that balance in there, was that we wanted to make it clear that our intention was to be good stewards of public dollars, and also to make sure that we were investing where those investments were needed to reduce disparities and improve health. And so trying to communicate both of those things was the intent. I'm glad that you see that strong commitment to stewardship alongside the fact that we don't want those cost savings to be at the expense of people's health. And so that's going to be all of our work as we move forward, is to make that actionable, but hopefully you see that balance struck.
Yeah, no, it's in there, and that's exactly what we want to do. So thank you.
Okay, is there motion on the table? Does the board want to propose a motion to adopt the 5 overarching principles and supporting statements as outlined in the values and principles work group recommendations that are dated August 15th, 2024?
So moved.
Second.
Great, and let's do a roll call vote, please.
Wonderful. Helen Malunka,
Yes.
Debbie Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Goldberg,
Yes.
and Judy Richardson.
Yes.
On behalf of all of us, I'd like to thank the work group for their work on this. This is a tremendous piece of work. It's going to be one of our foundational documents. It's going to be public facing. It's going to guide the committees and the rest of our work moving forward. So thank you very much for the thought and consideration you put into this. It's really appreciated.
If I could just add to that, appreciate particularly the work of John Chi, who contributed to this, and to public comment, which helped us do a better job.
Go ahead, Deb.
No, it was gonna be thanking Thomas.
Yes, great. So we are going to take a break before our next agenda item. I think we'll reconvene at 10:20 instead of 10:30. Is that right? Is it 10:10? Yeah. 10:20. We'll reconvene then. And if you need refreshments, there's some on the basement level, and take a break. Okay, welcome back, everyone. Oops. Welcome back, everyone. We are reconvening. The next item on our agenda is to review and possibly formally approve a preliminary structure for the universal health plan. This has come up in a couple of meetings before. The point of this agenda item was to clarify for outside parties, the new folks joining our committees, as well as outside contractors, technical assistance folks, kind of a rough draft of where we think the plan is going. So it's a communication tool and it is a starting point, right? Many of the items in this preliminary structure need a great deal of work and thought and input from experts and community members to decide if it's the right way forward. But just as a draft of where we think it's going, we'd like to review this preliminary structure, see if we've captured all of your feedback in an accurate way, and then if the board is ready, possibly approve it to move forward. That work? So yes, so the goal of the preliminary structure is to create a communication tool for our outside participants and also to meet our Senate Bill 1089 recommendations, to consider these recommendations. Next slide. We've had some additional feedback since our last meeting to the preliminary structure, including clarifying roles of TPAs and other regional payment authorities. We had some input on our problem statement, which I had pulled from the task force report, and some thoughts about maybe we need to think through more of the problem. That is not going to be part of the official preliminary structure, but I think it's a worthy exercise for us to think through what's in our problem statement, including consolidation, corporatization of healthcare, which has been a real big issue in Oregon lately, as well as acute shortage of providers in the workforce, both in primary care and in behavioral health. Yeah, so that was the feedback that we got. So this is the statement of the problem that's pulled from the task force, and the highlighted portion was feedback that we received, and I've put there for your consideration. That our healthcare is inefficient, expensive, and complex, relies on multiple payers, relies primarily on employment for insurance access, uses different benefits, different provider networks, different plans, and then every year thousands of Oregonians are uninsured. Healthcare in Oregon is inequitably delivered. Too many endure unequal access, varied care quality, and wide-ranging outcomes because of race, age, income, geography, insurance, and I would add inefficiencies in healthcare systems. And then high healthcare costs generate debt and bankruptcy for many Oregonians. So that's kind of what's driving the work that we're doing here on this board. The addition was to consider recent consolidation and corporatization, which leaves people with less sense of control, and acute shortage of providers in specific areas such as primary care, regional care, and behavioral health. Any thoughts or comments on the problem statement? Do we feel like the problem statement adequately captures the challenges we're trying to address? Okay, yes, okay, good, okay, thumbs up. Okay, great, so again, so we have 12 now preliminary structure components. So the word recommendations on this slide does not mean that these are our recommendations. This is the recommendation for what the preliminary structure looks like. So we're trying to be careful about our wording. So I'll go through these. These are the revised preliminary structure components. And I do have the old ones with me, and I could comment on, highlight what was changed if we need to. So first, all people who live in Oregon qualify for the universal health plan. We have added the statement, the plan will clarify eligibility requirements, including for people who live out of state but work in Oregon. Number two, the plan will be based on current PEB benefits and then we've added and will expand behavioral health benefits. We removed the language in there about Medicaid and Medicare because those are details that need to be worked out and are covered in the other parts of the structure. So people who qualify for long-term supports and services will continue to receive benefits and services through Medicaid and the Oregon Department of Human Services. And then we changed the second sentence to say the plan will explore coverage of some skilled nursing and home health care. Number 4, the plan will not require patients to pay when receiving care. There shall be no co-pays, deductibles, we've added, or co-insurance. And then this sentence was changed to read, instead, there will be new revenue sources that will fund the services while protecting families and businesses from financial hardship. Number 5, people who qualify for Medicare will be covered by the Universal Health Plan to the extent allowed by federal law. In our public comment, we received consideration of changing this number 5, if you could put that one, changing this number 5 to people who qualify for Medicare will be covered equitably or will be equitably included in the Universal Health Plan. So that's a consideration we can discuss. And then moving on, number 6 is the plan will work with any individual, group practice, or institutional provider that is licensed, authorized to practice in Oregon in good standing and provide services covered by the plan. Number 7, the plan will pay providers, and we added or provider networks directly. The rates of pay will be set up by region to account for different healthcare needs and costs in parts of the state. And then we added the statement, the plan will consider the role of TPAs and regional payment authorities. Number 8, health insurance companies would only be able to offer insurance to cover benefits and services not offered by the Universal Health Plan. We added the statement, the plan will need to clarify the role of workers' compensation insurance. Number 9, this is unchanged, Universal Health Plan will uncouple health insurance from employment. Number 10 is unchanged, the plan will seek whenever possible to address social determinants of health. 11 is unchanged, members of the 9 federally recognized tribes, including tribal providers in Oregon, have the option to participate in the plan. And number 12 is unchanged, the plan will be overseen by a nonprofit corporation. So the question is, did we capture in these 12 statements, people's feedback and concerns around our preliminary structure? Is there anything missing? Is there anything we need to add? It's kind of our last chance to say, this is what we think our structure should look like. This is a starting point for our committees, for our consultants to work from. And of course, any of these can change as needed, but as a preliminary structure, does anyone have any questions, thoughts? Did we miss something?
I'll go
Yes.
just to get things started here. I think there is actually some potential for dual meaning on universal health plan will uncouple health insurance from employment.
Yeah.
So as we pretty clearly, in speaking for those of us on the task force, we wanted people to be able to change jobs, to not have whether they got health care. Whether they got health care or not depend on whether they were employed. So that is a very important thing. Another thing that is more controversial is, and it appears in our values and principles, that we're actually by time funding of employment or funding of healthcare specifically to employers. There's a lot of economists that say that that's reducing employment. So there's actually kind of two things that are going on. There, one is pretty clear, the other is less clear. But I just want to be, I think when the task force was looking at this, it was looking more at the generic. We don't want access to depend on employment. That's just, I didn't think that was clear.
Do you feel like that statement needs to be changed, or is it okay as it is?
I think it comes, the task force put time into saying what we said. I would hate to change it without more discussion of the board. I think it's fine the way it is. It just, when I see that, it strikes me that some people think it means one thing, some people think it means something else.
Any other comments, thoughts on any of the statements?
Just, again, preliminary, if we just keep stressing preliminary and that these things could change,
Yes.
I'm fine. I think some of them have a bit of a duality to them that needs to get worked out. For example, I'm not terribly comfortable with number 7. And it goes back to our efficient use of resources question. It says that the payment rates will be set up by region. I don't think they'll be set by region. I think they needs to be set by the board and recognize regional differences. What if one region wants to get paid 10 times more than anyone else? I don't think we're deeming authority for setting payment rates to regions. I think we're recognizing that there are regional differences and that the plan will need to account for those in its payment. But we're not giving autonomy to regions to set payment rates. Is that,
Yeah,
and that's just, so I don't know that we need,
yeah, I think that's an important
Yeah.
distinction, so we could change number 7 to say, the plan will pay providers or provider networks directly. The rates of pay will be set up by the board and account for regional differences in healthcare needs and costs. That captured.
say it again.
Okay, the rates of pay will be set up by the board. And will account for regional differences in healthcare needs and costs.
I like that.
Okay. I think that's,
And I would. Words are important.
yes,
I might just delete the word directly from the first. From number 7. I think. Apropos of our previous conversation about payment and financing, it could happen in a variety of ways. But I'm fine with it as it is. I don't think it warrants us getting, I think that's the kind of discussion we're gonna need to have at the plan design work group, but.
yeah,
Yes, and a little bit of I didn't insist on any wording change, but this is a little bit like, here, catch.
Well, we say, on one hand, we say directly, on the other hand, we say there's gonna be a TPA or a local administrator. But again, I just,
yeah, so considering TPAs, considering where risk will live, like all of that has to be worked out. 7 is a tricky one.
Yeah.
Somehow providers will get paid.
yeah,
What about the feedback we got on number 5 about Medicare? Oh, yes, so Michelle, go ahead.
Just to add to this discussion on 7, and we may not need to change anything here, but I'm trying to think of some of the things that'll flag concern, maybe unnecessarily, based on the fact that this is very preliminary. And I hope that that'll be very apparent to anyone who looks at this document in the future. But I think that a tension that we're all aware of is that there are regional differences in needs and resources and strengths across the state, and that there is a history and in some ways a fairly grounded fear that people in Eastern Oregon and the coast and Southern Oregon and Central Oregon have, that these decisions will be made unilaterally, centrally by the urban center of the state and not include their direct feedback. That like someone in Portland will decide what Eastern Oregon needs, like that whole tension. And so that this wording about, I do agree that the rates need to be set by the board and will account for regional differences. I just hope that for folks reading it, it will be apparent that accounting for regional differences includes incorporating, direct feedback and guidance from people who live and work and do this health, have healthcare practices in those regions themselves. So just wanted to note that.
Do you think we should add wording about that, or is it just kind of a note to keep in mind?
It's at least a note to keep in mind. I think account for, will be set by the board and will account for regional differences. Yeah. I have no succinct way to do that in this moment, but I do want to just say it for the record for those who may be listening now. And if there is a succinct way to include that, I think that it might be worth it.
Okay. Any other thoughts or comments, or we can go back to number 5?
I would just add on to that, Michelle, I share that, although I share it from the opposite perspective. I get concerned that large metropolitan areas like Portland eat up all the resources. And that shouldn't be.
Yeah, and that ties back to who's making the decisions. In
Exactly.
at least that's part of the perception for sure. Yeah, those are linked.
Yeah, there's a health equity piece on 7 that isn't exactly called out, but a way of, right, making sure that access and quality are really thoughtfully done, you know, sort of at the board level when accounting for regional differences and really thinking through right, who gets care when, and you know, how much care is available to whom. And
I
Can
think
I-
that's the whole tension in this whole thing, is that
Yeah.
it needs more words, more explanation, more clarity. And it's the risk of putting something out that's preliminary like this, but I'm fine with it.
Can I make a quick friendly amendment proposal that we just add to the end of this excellent sentence that was captured by staff? In consultation with regional entities. Would that be enough for now? It's not saying that they will make the decision or we will make the decision. It's just saying that there will be some conversation and folks will be included in that conversation.
Yeah, that works.
What am I adding?
So at the end, after costs, needs and costs,
Uh-huh.
put in consultation with regional. What'd you say, Michelle? Regional
Entities is the word I used.
entities or representatives, yeah, regional entities, yeah, okay.
Thank you.
Anything else? Okay, let's go back to number 5. So the feedback we got back on number 5. So right now it says people who qualify for Medicare will be covered to the extent allowed by federal law. This is to account for the fact that waivers are necessary to fully incorporate Medicare. We may or may not recommend applying for those waivers. We may or may not get those waivers. And I think the idea from my reading of the public comment was, in the case where Medicare, for whatever reason, cannot be included in the universal health plan, and it remains as a separate benefit, then there will be, one of our goals is to make sure that there are no incentives for providers to see some patients over others. Medicare rates are historically much lower than commercial rates. If we set rates for the universal health plan that are higher than the rates paid by Medicare, then that inequity, that discrepancy still exists, and Medicare, folks on Medicare, the providers will be disincentivized to care for them. I think that was the gist of the feedback that we got in public comment, and so the recommendation was that whatever we do, that people who qualify for Medicare will be, the wording suggested was, people who qualify for Medicare will be equitably included in the universal health plan. Meaning that they won't be disadvantaged because of the person paying for their care in terms of accessing care. Anybody have thoughts on that, or?
Well, I'm okay with, I mean, not to be a pest, but this is also an issue for, why are we assuming that Medicaid can be included?
Yeah. Yeah.
I mean, if you're saying
Because
the,
I think the state has more authority over that, or they don't,
you need a federal waiver,
yeah.
you would, I just.
Yeah.
And there's two aspects to this. One is assuring Medicare recipients that we have their back, they're not gonna lose anything. But the other consideration, as you said, is if we don't include it, will we lose all the money, the cost advantages that we hope to use to create more equitable, that we hope to do good things with? You know, do we lose any ability to gain a financial advantage and or equity?
Right.
So those are all things that need to be considered, but for me, you know, this is kind of an act of, you know, congratulations committees. You had some things to look at here, the task force. Had some ideas about these, or has a few ideas, but these are really things that will have to be determined at the committee level.
Right, so there's like two things here. One is that, regardless of payer, we don't want there to be a discrepancy in how providers are paid. So, based on who the payer is, so we've got to equalize, that, payment structure. Even if, for whatever reason, we're restricted from incorporating, some components of the healthcare system into the universal health plan. So that providers get paid equitably no matter who they're seeing. That's like one piece of it. The other piece of it that Warren just said was making sure we don't lose any benefits, no matter where they're coming from. So if it's Medicare benefits or Medicaid benefits, we don't want anyone to lose benefits on this plan. And that's a really important consideration. So I don't know if maybe we just need to pull those two things out separately instead of number 5. Judy, you had a comment on that.
I was just gonna thank Warren for that comment, because I was thinking about, it feels like this requires a lot more work in committees to dig in deeper. And how do you provide equity between Medicare, Medicare Advantage, and all of these different, I mean, there's nuance within that, and Medicaid, the CCO program, and how do you provide equity and benefits across the board? And I think that just will require more detail than we need to actually perhaps in a preliminary structure.
Yeah, so if we were to give some guidance about it, if we want the committees to work on this, and we would say, here's where we want you to aim. That's kind of what we're trying to do with these statements. We want you to aim toward providers get paid the same no matter who shows up at their door, and we want you to aim toward people not losing any benefits no matter where they're starting from. Yes, good. Amy?
Oh, I think Michelle was first.
Okay, Michelle.
Thank you. My thought is maybe number 5, we could say we will work to eliminate disparities in provider pay that disincentivize or that would create barriers to equal access to care, or something like that. That's a little steps back a little bit and aims more at the plain language of what you, I think, just said earlier, Helen. And then that would kind of cover our bases, and we could include to the extent allowed by federal law. But I think saying what we mean is maybe the simplest solution here.
Would you preface that by a statement that said, in the event the state is unable to attain Medicare or Medicaid waivers, then, because that's what we're talking about. We're talking about
Yes.
in the event of an inability to get waivers, then we don't want there to be disincentives for
Yes.
provider communities.
That's
I mean, to me, this starts with, the whole notion is we want the plan to include, I mean, do we want the plan to include Medicare and Medicaid?
yes.
Yes or no? And then if yes, we need to get waivers. And then the question is, if you can't get those, then what?
Got it. Yeah, that's excellent. So in the event the state is unable to obtain federal waivers, the plan will eliminate discrepancies. The plan will aim to eliminate discrepancies in provider payment based on payer. Is that right? That's awkward. So the event the state is unable to obtain federal waivers, the plan will aim to eliminate discrepancies in provider payment.
Michelle said it well.
Yeah, what'd you say, Michelle? The plan will aim to eliminate discrepancies in Or, yeah, provider payments that disincentivize.
Equitable access to care.
Equitable access to care, disincentivize. Disincentivize equitable access to care.
Or something to that effect.
Yeah, yeah, I love it. And something about benefits. So, plan will aim to eliminate discrepancies in provider payments and maintain current benefit levels. I don't know how to, that's rough. And,
And-
and,
My comment was, oh, sorry.
sorry, so, not lose any benefits people are entitled to by virtue of federal programs? I don't know, like, something along that line.
Hmm.
Jump in. Go ahead, Amy.
Yeah, my comment wasn't necessarily tweaking any of these words, but kind of goes along with that last, maintaining current benefit levels, and just that making sure that the board's aware and the people who are joining the committees that right now they're just starting a process of changing the Health Evidence Review Commission, I think is the CHERC, and the it just went on my brain, the magic line, the
Prioritize list.
prioritized list, thank you, is going away, and they are going to be in a 2-year process of doing community engagement and getting feedback on this change at the same time that we will be doing our process. So I just want us to be very aware and make sure that some of us, and I'm paying attention to that process, but that some of us are paying attention to that because we will want to know what's happening.
Judy, go ahead.
My comment was captured. Thank you.
And then Michelle, did you have something else?
I guess this is just more of a question. I know we're striking this balance of giving guidance to the subcommittees and also being general enough to not get in the weeds and do the work of the subcommittees now in real time. And that this is a working document, but I just wonder, to me, the goal of eliminating discrepancies in provider payments that disincentivize equitable access and trying to make sure that folks don't lose benefits is captured in all of the things that we've talked about. That's why we're applying for waivers. That's what we would do if the waivers are denied. That's how we would write the waivers. You know, it would guide any and all of the above. And so I'm wondering if we're overcomplicating it by, I think if a member of the public read this, they would have no idea what we're talking about. And so that's my question. Could we simplify this by saying, here's our goal. We want to eliminate, any incentives to any provider payment discrepancies that would reduce access to care. And we want to make sure people can keep their benefits. And then we've got a bunch of strategies to try and do that based on what gets approved and what doesn't. But I wonder if we're overcomplicating this because we're in the weeds a little bit.
Yeah, I do think the issue of federal waivers is important enough to call out. I mean, that is going to be one of our major stumbling blocks in it. And as a state trying to do universal health plan, like that's going to be our biggest, that's the biggest difference between the state trying to do it and the feds trying to do it. So I think in this situation, I think it's worth calling out the federal waivers and just saying that in the event that engaging the feds on this is it's a little bit out of our control, and if we can't engage the federal government in this, then in spite of that, we want to maintain equitable access and have folks not lose benefits to the extent possible. I think that is worth calling out as a direction to committees, because there is a real possibility they'll say, well, we can't get a Medicare benefit, so therefore we just leave Medicare alone and focus on everybody else. And that's what we don't want to have happen. We want them to really then, if that's the case, what would you do then? Like, right, we want that to take that to the next level and make sure that we do some sort of wraparound for Medicare or something along those lines to have everybody have equitable access. I would be in favor of keeping the mention of that in there for that reason. But you're right, it is kind of more generally like eliminate discrepancies.
So then my follow-up question is, we have received some public comment expressing care along the lines of hands-off Medicare. Is it clear in reading this that if the federal waivers are approved, that our goal is still to maintain equitable access and make sure folks don't lose access to care?
Oh, yes, that's a good point. Yeah, okay. Oh. Okay, the plan, how about if we phrase it as the plan will eliminate discrepancies in provider payments, so start with that, whether or not like waivers are achieved. How about if we put that at the, whether or not waivers are approved, I don't know what the right word is there, the verb. But the plan will aim to eliminate discrepancies in provider payments that disincentivize equitable access. And to maintain current benefit levels. Regardless of whether federal waivers can be obtained or not. Does that work? Thank you, Michelle, that's really good feedback. Any others, like, does that work for number 5? Okay. Yay, comments on any other recommendations? Or they're not recommendations, comments on any other statements in our preliminary structure? Okay, so I wonder if there's a motion to adopt we gotta get rid of that word recommendations. To adopt the 12 components of a preliminary structure for the universal health plan.
I'm a little uncomfortable saying that these are everything that the committees need to take into consideration. There's other things in SB 1089. We're merely passing on the things that came from the task force.
Yeah, very exactly. So it's all preliminary, it's all just a starting point, but when people are thinking about what they're trying to build, is there a way to change the word recommendations in there? Yeah. Adopt the 12 components of a preliminary structure for the universal health plan.
Sorry, could you repeat what you wanted to say?
Get the word recommendations shouldn't be in there. These are not recommendations. The governance board, proposed motion is governance board adopts the 12 components of this preliminary structure for the universal health plan. As a starting point for future work.
Yeah, and my point is, there's a whole lot of things that are important to the committees that do not appear in these task force recommendations.
Yeah,
For instance, there's not a lot in here about finance, for instance, because the task force never made any recommendations about finance. So we're only just passing on these 12 things that the task force did present.
yes, so, right, and so so this is just kind of our job is to consider this, because this is what 1089 asks us to consider the recommendations of the task force. And officially acknowledge them, adjust them, modify them as needed. And then this will be one thing that we are charging the committees to do. Yes, the committees have tons more work on what's in here and other things as they come up. It's basically that we agree that this is a starting point and we're gonna take it from here, from where the task force left off. But these are the things we're gonna carry forward as a preliminary structure, and then it has to be expanded and developed from there.
Amy has a question or comment.
Go ahead, Amy.
Just I don't want to take us back to the previous screen, but just remind me on the comment that talks about expanding the PEB benefit and then further expanding behavioral health. Is it assumed that dental is included in that PEB? Or are we not even touching that? I'm just reminded, I was at the HERC meeting yesterday for folks with disabilities, and we was reminded about adults with disabilities, having teeth pulled instead of getting root canals and things like that. So I'm just wondering like where that falls in this.
Can you go back to that one, Katie, the
Yep.
slide that has that listed?
Oh, yeah, just. Ooh. Anyone remember what number?
It's in the first, yeah, it's 2. So does that include, does PEB include dental? Have we even, can't remember if
So-
we've talked about that or not.
We can clarify it in number 2 a little bit more, but the idea is PEB benefits are like a starting point. They're not sufficient, but they're a starting point. I do believe they include dental, but it would be a starting point because we definitely need to expand behavioral health needs. It's just, behavioral health benefits. It's just kind of like a set of benefits to work from as a starting point. Like everything else on these, it's just somewhere to start from. Let's start with this and see what needs to be added. Because again, we don't want folks on Medicare, to lose benefits or Medicaid or any other program. So with the, like, if we used PEB, what do we need to add to PEB in order to make it a comprehensive plan? So we can make that more explicit in number 2 to say the plan will use PEB benefits as a starting point and will expand behavioral health benefits and consider any other necessary additions, something like that. If that works. Would that address it, Amy?
I think so. Yeah, I just had
Okay.
forgotten where we were on that whole topic of dental.
Yeah, so the plan will use PEB benefits as a basis for a benefit plan, but will expand to cover more services, including behavioral health and other services identified. I don't know, I'm making talking off the cuff here, but plan will use PEB benefits as a basis for a benefit plan. And let's do and will expand and will expand to cover more services, including behavioral health and other services as identified by the committee. As identified, I don't know. Help me out.
I think this is part of the
Yeah,
problem of sort of going quickly through some of these without.
right,
I was gonna edit the motion.
okay,
To make it a little bit more broad, that might be helpful, to say something like. The governance board suggests, not adopts, but let's suggest the following as a starting point for the preliminary structure of the universal health plan. I think,
okay,
in my mind, that provides, I think what we're trying to
Yes.
do is a preliminary structure and some suggestions, not this is how it's gonna be. And words are important, and I think we're all, every time we read these, we come up with more questions. So being a little more broad in what the motion is might make some of us a little bit more comfortable with the lack of
yeah,
discussion about each of those items.
yeah, I think that's a good point. So the governance board suggests that these 12 components.
I was just gonna suggest the following
Suggest the following,
as a starting point for their preliminary structure of a universal health plan.
Or would you accept the word for consideration?
Great,
suggest the following components for consideration of a preliminary structure for the universal health plan, and then get rid of it as a structure.
Yeah.
Okay, so the governance board suggests, the proposed motion is governance board suggests the following components for consideration of a preliminary structure for the universal health plan. And then it would list the 12.
Yeah.
And I can't live with, implies that this is the primary, and I consider that this is a part of. So for consideration, it's the A.
As, so Debbie suggested as for consideration as.
Yes. Okay,
Consideration as. A preliminary structure. Need an A in there, Katie, yeah.
thanks.
Would anyone like to make a motion?
I was gonna say, in number 2, the one we just edited on the benefits, we had additional services kind of listed before mental health and after mental health, and we could probably eliminate one of those to make it.
I need to take it off the screen, but I will take that.
Yeah. I want to make sure that the benefit one specifically calls out the expansion of behavioral health, but we just be there. Okay. Any other thoughts, questions, concerns? Anyone ready to propose a motion? Okay, Debbie's making a motion that the governance board suggests the following components for consideration of preliminary structure with the edits that were included. Is there a second?
Second,
Any discussion? Okay, let's do a roll call vote.
Wonderful. Helen Blanca,
Yes.
Debbie Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes,
Michelle Glass,
Yes.
Chris Goldberg,
yes,
and Judy Richardson.
Yes.
Yay, nice work. Thank you. Okay, so,
Just a moment.
kind of, this goes along with, this goes along with, the discussion we've already been having about this, which is, as we're launching the committees, we want to give them certainly leeway to explore various options in achieving the goals of the universal health plan, but also enough direction that they know what they're going to be taking on and what they're going to be asked to do. And so for the committees, the primary document that we'll be giving them is their work streams and the deliverables that we're asking them to do. That's primary. And then we would also give them the full list of these 12 statements to think about as sort of a component of what a preliminary structure will look like. And then we sort of divvied up these 12 recommendations according to which committee we thought would most need to consider them and work them out. Now, we noticed, of course, that the bulk of the recommendations from the task force, the bulk of the 12 that we've just considered, really fall in plan design. That's where the task force spent most of their time and effort, and as Warren has pointed out, there really isn't enough at all on finance and revenue. There's a bit on operations, and in terms of communication and community engagement, none of those task force recommendations and this preliminary structure that we've agreed to, none of that address those. What this means is that most of the work has already been thought through in plan design, and the bulk of the work of the committees really falls in operations, finance and revenue, and communications and community engagement. So that's where the work needs to happen in the committees. So we don't want it to feel like, plan design is where all of the effort is going. I would look at this and say plan design is where the effort has been so far, and we need to flesh out all the other pieces of the plan. So we'll be pointing to these, so each committee will get the full list of 12, as I said, with the ones that we feel like most live with them kind of highlighted for them to consider and work through and sort of flesh out even more. As well as on the next slide, we'll get to some additional questions that we're starting to generate. It's hard to see on the slide, but we've divvied up the recommendations. And we wanted to kind of get feedback on whether or not we divvied them up correctly. When we did this with Warren and I and staff, we were all pretty well aligned with where they all fit. And again, all the committees will be considering all of them, so it's not like they can't consider them. There's a lot of overlap. There's going to be a lot of tossing things back and forth. It depends on what this committee wants to do about this, how we go on this direction. But there was pretty good alignment at divvying them up. I'm not able to read them from here.
I can.
Yeah, so briefly talk about which ones are in which group.
Yep, starting with plan design. Members of the 9 federally recognized tribes in Oregon, including tribal providers, can participate in the plan. Do you want me to read them all or do we want to pause?
Yeah, read them all, what's in plan design
Okay.
expenditure.
All people who live in Oregon qualify for the universal health plan. The plan will clarify eligibility requirements. The plan will be based on current pet benefits and will expand behavioral health benefits, which of course we did edit that one. People who qualify for long-term supports and services will continue to receive benefits and services through Medicaid and the Oregon Department of Human Services. The plan will explore coverage of some skilled nursing and home health care. The plan will pay providers or provider networks directly. The pay will be set by region to account for the different health care needs and costs in parts of the state. The plan will consider the role of TPAs and regional payment authorities. The universal health plan will uncouple health insurance from employment, and the plan will seek, whenever possible, to address social detriments of health.
So those are the ones that we felt kind of lived in plan design expenditure. Many of them actually speak obviously to benefits and eligibility, which is what that's about. The one in there about uncoupling insurance from employment is a really interesting one. If that goes in plan design expenditure, or if it's more for the operations committee or for finance and revenue, it kind of lives in all of them. That was one we weren't sure quite about, but does anyone have any other kind of qualms or context for if those go in that category?
Are we just looking at plan design?
Just plan design.
I think there's others that go in there. But I don't know if we want to do that when we go through the rest.
Yeah.
I mean, those all seem to be fine for what goes in there.
Yeah, so go through the rest, Katie, that's
Okay.
interesting.
Finance and revenue. The plan will not require patients to pay when receiving care. There shall be no co-pays, deductibles, or co-insurance. Instead, there will be new revenue sources that will fund the services while protecting families and businesses from financial hardship. Moving on to operations. People who qualify for Medicare will be covered by the universal health plan to the extent allowed by federal law. The plan will work with any individual, group practice, or institutional provider, including hospitals and health systems that are licensed or authorized to practice in Oregon in good standing and that provide services covered by the plan. Health insurance companies would be able to offer insurance to cover benefits or services not offered by the universal health plan. The plan will need to clarify the role of workers' compensation, and the plan will be overseen by a nonprofit public corporation.
So I had a thought about, I mean, to me, the Medicare discussion is a plan design issue. It's not an operational issue. Operations figure out, once you design a plan, operations administer and implement it. That's just how I think about this. So I mean, I think the Medicare piece is an eligibility of plan design kind of a piece. You know, and the health insurance and workers' comp pieces are also kind of plan design in my mind. I mean, I think that's why we have operations coming later, is once all these decisions get made, how you actually set up and administer the plan is the work of the operations group.
Judy, go ahead.
I wonder if there are actually a couple of them that do live in communications and community engagement, specifically members of the 9 federally recognized tribes and the plan will pay providers or provider networks. Those are going to require a community engagement, like intentional reaching out and a conversation. Maybe not immediately, but certainly part of their work, I think.
Yeah, Amy.
Yeah, I was just gonna comment also about the lack of anything under communications, community engagement, and just that it seems that we will need to develop some kind of intentional feedback loop, like at different stages of, you know, before decisions are finalized, or I'm not sure, but a way that we can get broader community engagement than the plan design committee, you know, or, you know, the other individual committees as things are developed.
That's right. Yeah, absolutely. And I'll reiterate that, you know, what's here is based on the work that's been done to date, and the blank spots, the more blank spots there are, the more that emphasizes this is the work that we have going forward. So the fact that it's blank doesn't mean that there's no work. It means that that's where most of the work needs to happen, because that's what really hasn't occurred yet. And so we've got to take, this is what we've given as a starting point, and this is where we've got to take things. So yeah, go ahead, Michelle.
I just wanted to note for the board members and also for the public watching that there is in the preliminary work plan of the community engagement work group, some of those intentional engagement that was like in the bill is already on the work plan. But in addition to that, I would love to hear from each of these other work groups as they get started. Are there things now, based on where we are at and our starting point, that you think you need or you would like to direct us as the community engagement and especially communications committee? Like, what do you see plan design and expenditure committee as supporting your work as you get started? Is there a one pager that you need that summarizes something? So I would just welcome that feedback from the first meetings. We do have a work plan and we have plenty to do, but I think if there are immediate gaps and needs in communications, since there wasn't a lot of capacity for that in the task force, I would like to figure out, what that communication looks like, because I think that is important to catch sooner rather than later.
Bruce, go ahead.
Yeah, second, what Michelle just said, looking at it a different way, it just seems to me all those things that everything up there needs some community engagement and input, as opposed to us just saying, well, here's what we think has to be. So I would think communications and community engagement need to be involved in all of those things, not just one or two, but and getting that up front makes a lot of sense, Michelle.
Yeah. So when we talked about this, we talked about sort of which committee had primary ownership over these ideas or components of the program. But all four committees have to consider all of them clearly. It's just like if we had to assign a primary owner to it, where would it live? We can reconsider that, and sort of there are a couple in here that probably should be assigned more than one. The way we've been thinking about it is, the Finance and Revenue Committee is about how the money's gonna come in. And although it's called Plan Design and Expenditure, the plan in this context doesn't mean the whole universal health plan. It means like the benefits, it means the design of the benefit package and how providers will get paid. So plan design and expenditure is how the money would go out from the plan. So what benefits are covered, how would they be paid, how does that work? Operations, we're thinking more as like systems work, like what is the role of the Treasury setting up the trust fund? What is the role of OHA? What is, how do you actually do the nuts and bolts of that work? And my thought on the insurance companies is there will be insurance companies that operate outside the universal health plan, right? There will be commercial plans that cover benefits not covered. And then there's this workers' comp issue. And my thought on operations was, at some point, we need to think about what outside of the plan, how can insurance companies operate, right? Like what is the relationship between the universal health plan and healthcare coverage that is not in the plan, whether that's workers' comp or commercial covering other benefits? And because plan design and expenditure was really focused on the actual benefits delivered under the universal health plan and how those will be paid, I thought, other people have different considerations about it, but I thought that things like workers' comp and the role of commercial payers outside the plan should be really thought through in a separate context. But that's kind of where that came from. But yeah.
So we should probably have a discussion,
Okay,
perhaps not now, but
yeah,
offline, about the role of the operations committee.
okay,
Because as the chair of that.
Yeah.
I actually thought it was actually more about how you're gonna operate a health plan.
yeah,
That how you were gonna structure dealing with issues of quality, payment, costs, information systems, all those issues about how you're gonna, a plan
Yeah.
for how you're going, you can't just say, we're gonna do this. And then the next question is, okay, so how?
Right.
Over the net, is this gonna be start in
Yeah.
1 year, 5 years, 10 years?
Right.
How's it gonna be structured? What kind of staffing are you gonna need? How's it gonna be organized? What is gonna be what are the startup costs? I mean, I viewed it as purely operational. The questions you put out there to me were policy questions. Are we gonna include, workers' comp or not? To me, that's a policy question about plan design, not an operational question about how you're gonna now take what are a couple hundred health plans that operate in the state and now have a single plan that operates, and how are you gonna structure that? Where is it gonna sit? How are you gonna fund it? All those issues, to me, were operational issues, so we
Yeah.
should probably talk a little bit and look at the charge, not right now,
Yeah,
but I guess I'm just thinking about it.
yeah,
I mean, maybe I'm more concrete, but I thought the policy work gets done in the plan design and revenue, and then the operational side
Just
kind of
that.
takes
Yeah.
over.
Yeah.
And that's why we also structured it so that it starts meeting
Mhm.
later on, because that's part of to me, that's part of the other piece that the operations committee is supposed to do, which we keep spending little time on, and to me is one of the most important, which is then an implementation plan. We're about to take 20% of our state's gross domestic product, something that affects every single person in the state, and how we're gonna implement that. I mean, to me, it's just critical.
Yeah,
And unless we can clearly articulate how we go from where we are today with a healthcare system to a very different vision of what a healthcare system is, that's gonna affect everybody in the state, how we're gonna implement that, well, yeah, I think the first question we're gonna get asked is, okay, so how what's your implementation plan? And I guess that's what I viewed the operations
Mhm.
and implementation committee is doing.
Mhm.
If I'm off, then we should probably
Yeah.
have a bit of a discussion.
No, and speaking as the assigned chair of the Finance and Revenue Act, the same thing, and in fact, the one thing that's under finance and revenue to me is plan design. But I think this discussion is very good and it highlights, among other things, the way that we need to coordinate, that I suggest. For now, we have another topic
Yeah,
to get to,
Yeah.
if we can kind of make a note of some way to coordinate between committees or something to kind of resolve a few of these.
yeah, we will do that. We are planning on meeting with each of the committee chairs to think about adding new members, in which, who's gonna be on. And so I think as part of that, we can work through some of these questions
that'd be great.
and figure it out. Yeah, so we'll do that. Yes, Michelle.
I know we need to move on. I just wanted to make a recommendation or a suggestion for consideration that we add an agenda item, and it can be really quick for each subcommittee meeting where we just quickly discuss as a committee any updates or requests or questions we have for other committees. Again, to Amy's point about how we need these loops, these communication loops, and we need to find a starting point to create those. Just one way to perhaps start.
That's great. We will definitely include that. Committees, questions they have for their own work and then questions they have for the other committees, those will be like ongoing lists, yeah. Excellent. Okay, so we will pause on that and get back to you on that as we develop the committee work further in September. So we'll move on to excellent agenda item about committee recruitment. So Morgan, can you give us an update on committee recruitment?
Yes, thank you. And that was a very good transition. So just a quick reminder, we have been recruiting for 4 committees. Okay, we need a couple more minutes to figure out our technical difficulties. So thank you everyone for your patience, and we'll be right back. Oh. We can just keep going.
Yeah, and maybe just is that you, Morgan, at the microphone, if you can repeat when other people in the room say things, since we can't hear them as well, or people can speak up or something.
We'll turn on our mics when we speak. How's that?
Oh, that's perfect.
Yeah. And then we'll introduce ourselves.
Okay, so Morgan was in the midst of a committee recruitment update and said we've got 166 applicants total, which is great.
Thank you. This is Morgan. Yes, I will continue the committee recruitment update. We closed their committee recruitment on Monday, August 12th. We have 166 total applicants for the 4 committees. We did receive from Friday to Monday, 62 applicants of the 166 came in that last weekend. So kudos to you all for extending the deadline and allowing us extra time to do a lot of outreach. I was in the middle of sharing some of the outreach we were doing in terms of meetings with partners, emails out. Katie had developed a recruitment email to share with the board, so you could all use that with your networks. In addition, OHA was able to send it out to 2 of their distribution lists, which really extended our reach. So that was a great idea that was discussed at the board meeting last month. Of the interested applicants, we asked each applicant what their first choice for a committee was, and then if they'd be interested on others. And of those initial, kind of their top choice, we have 40 interested applicants for communications and community engagement, 20 for finance and revenue, 26 for operations, and the most interested committee was plan design and expenditures with 76 applications. Staff has started reviewing those applications. We've developed a scoring methodology to look and see if the expertise and experience matches kind of the roles and functions of that primary committee. But I'm also very pleased that many of the people really are just very interested in being a part of the work and have indicated second and third choice committees. So I think in the conversations with the chairs, we may also be looking to tap into some people who opted for plan design initially and look at them for other committees as well. I will also. I will also.
Or just unplug it. It's the merciful thing to do.
Okay, can you hear me now without an echo?
Yep, no echo.
Thank you. We've received applications from many types of providers, community-based organizations, healthcare associations, and many community and consumer individuals who are interested in being part of this work. So next steps, staff is using the scoring methodology to look at proposing a slate of potential applicants to each committee chair, and then working with the committee chair on the best membership to make sure that the expertise and experience that you want to see on the committee that you'll be leading is there. And then we will work to have a preliminary list of committee applicants posted a week in advance of the September meeting. They will be preliminary. The board is the only entity that can appoint members to the committees. So we'll let the committee members know that they've, that their name is on a list preliminarily, but that it's really up to the board to make that final decision about the committee membership for all of the committees. At the last board meeting, we did talk about having an extra meeting in between August and September to try and move quickly. And we tried to schedule that and we're not able to find a time that did not put at least a couple of the board members at risk of missing 2 consecutive board meetings, which in our policies and in state law results in kind of unfulfilling their term. So we're looking to make the appointments, we're looking for you to make the appointments in September. And then our plan is to also be simultaneously scheduling an orientation meeting for right after that board meeting where we would be having some training for all of the committee members about public meetings, public records, the task force recommendations, some of the basics that all of the committee members would really benefit from, and then be able to start those more issue-specific committee meetings after that and work with them to find the best time for those.
Okay, can I make a quick suggestion just about that training?
Yeah.
Maybe you could record it and then if people can't make it, they can just watch it that way. I'm sure we schedule something and a lot of people won't be able to do it.
Yep, we were thinking of both, I mean, we will record it because it would be a public meeting and would be available on our website. And we were also thinking about potentially offering it twice because the topic would be the same, but then we might have different questions from committee members, but yes, that was in line with our thinking as well. So the staff is already working to think through what those materials are for that orientation and to make sure that that's available. And then, as I mentioned, then we'll be able to start those issue-specific committee meetings very quickly after the September board meeting. Any questions?
I just want to say thank you to Morgan and Katie and Jenny and all, and our OHA colleagues who, this has been a ton of work and the scoring is another ton of work and we really appreciate that. But I think that the process has all gone really well so far and we look forward to welcoming new committee members in September.
Thanks.
There are no other questions. We'll move on. The last item is going to be status report due to the legislature. So Senate Bill 1089 requires intermittent status reports to the legislature, and the staff has proposed a timeline and a process for the board to review and provide feedback on. So Morgan, can you tell us what the plan is for this?
Sure, thank you. And there aren't any specific slides for this item, but there is a handout that's posted on the meeting materials that the public and board members can follow along with. This is just a proposed timeline for the board to review and discuss and give us feedback. But as Helen mentioned, the board is required by Senate Bill 1089 to submit a status report to the chairs of the interim committees on health by December 1 of this year. So working backwards, that means the board would need to approve the report at the November meeting. So we'd want to make sure that the board had a draft of that report to review in October. So we're proposing that next month in September that staff develop an outline for you to review and give us feedback on what you want to see and highlighted in that status report at the next board meeting. And then we will work from there on the kind of filling in the content and bringing that back to the board in October and November.
Does anyone have any feedback or questions for Morgan on that proposed timeline? Okay, excellent. Sounds great.
Great, thank you.
Okay, so we just have a couple of minutes left and we have some public comment. So yes. Yes, so we had agreed at our last meeting that at the end of each meeting, we were going to take a little bit of time to talk about two things. One, key talking points. So you should have all gotten some documents in your email that have speaking guidelines when you're talking about the board's work outside of here to public interested parties. It will include a standardized PowerPoint with slides that we will help keep filling in, and then a PDF document with some standard talking points. And so the PowerPoint and the talking points document will be updated after every meeting. And so what we're hoping to do now is just quickly capture the key points from this meeting that we're going to be including on our talking points because we want you to be doing outreach. I have a quick list. I have that we approved our values and principles, which is fantastic. We have a suggested preliminary structure that we'll be using for our committees and for our consultants. We have had a great committee recruitment process and the applications are now closed. The selection for our committees will happen at our September meeting. And then our process for working with technical assistance and a formal contractor are well underway and are proceeding nicely. So those are the four that I had. If anyone else has key points from the meeting that you want to include in our talking points. Cool. So then the second part of this agenda item is asking all our board members about any outreach opportunities you've been invited to or any outreach you've been doing on your own, groups that you're talking to, just to kind of keep community engagement and public engagement a core part of what we do. We have a few minutes if anyone would like to let us know about any public engagement that they're doing about the board's work. Go ahead, Warren.
I was asked to speak to Mid-Valley Healthcare Advocates. They also invited people from One Pair States, which is a national group, just a couple of days after the last board meeting. It was a good discussion and people are always interested to hear more and ask. Many people had technical questions, which we'll be getting into as we get further along.
Great. Judy?
Thank you. So part of my day job is teaching MBA students. My intention is to bring to them the 4 financing models and get them to think independently about how would this work in Oregon, and then share a little bit of our work there. They're, I guess, quasi-public, but there are 30 students dispersed throughout healthcare. So thank you for the presentations today, and I'll be soliciting their feedback.
Amy?
Yeah, Michelle and I both are part of the Allies for Healthier Oregon Consortium, which is a program of We Can Do Better, and have not yet kind of brought any concrete updates, but could get on agendas, you know, for September or October meetings to do updates, and then just do short ones regularly.
Great. And Michelle?
And again, thank you for these materials and for this clarity on the process. I'll be following up with the folks who had reached out over the last couple of months requesting updates, specifically the Southern Oregon Healthcare for All Oregon chapter, as well as the statewide Regional Health Equity Coalitions collaborative to provide updates to those groups. And then Amy and I know have started a list of groups to do some proactive outreach to that we'll be taking to the committee. So those are some preliminary steps.
Excellent. Just as a quick reminder, we want to track the outreach that the board is doing. So please, if you have an invitation, certainly if it's a set date, please let Morgan know who you'll be talking to and the date. Please use our standardized materials and follow the speaker's guidelines that we've outlined. But yes, as the more people we can talk to and engage in the work, the stronger the plan will be. So we definitely encourage all of you to go out and talk to people with those guidelines in mind and letting us know when you're doing it. Any other thoughts, comments? Anyone else want to? What outreach? Excellent. Great. So we do have some time for public comment and we, yes,
Can I make a comment about public? Can I make a comment about public comment?
yes, of course.
And just a suggestion, as we move towards getting involved in some meaty decision-making around all the things we've been talking about, it might help us to have public comment at the beginning of the meeting if we're then gonna vote on things during the meeting, so that people have
Mhm.
input into those decisions or comments, as opposed to having voted on everything during the meeting and then having public comment at the end. So just, I think, something to consider as we move forward.
What do other board members think of that suggestion? It's great.
There isn't any one way to do it, and you do it. Often public comment is, there was something came up in the meeting and I want to comment on it. I want to comment on what happened in the meeting. And instead of, I want to comment on something you're going to vote on. So I think other organizations have tried both. I think, we have made, it's the way it is because we made a decision to put it there, acknowledging that anything that's on the agenda is available for written comment. And we could revisit that. Your arguments are good, but
Something for us to consider.
Yeah.
Obviously.
Right.
Yeah, and was that Warren, you and Helen made that decision with staff? Because I don't recall us having this conversation before.
Yes, it was just the policies and procedures have the chairs and work with staff to set up the agendas. So we had to decide where to put it initially. We're open to discussion on on how to change it. So.
Yeah, and yes, absolutely open for discussion. And I would say what I've been trying to do is review all the public comment before the meeting. And then in my introductory comments, sort of capture sort of any relevant public comment that is going to be relevant for our discussion today. And I think that happened today with Mr. Swanson's comments about Medicare and that, but we could do that more and we could make that more clear when it's clear that somebody wants to comment on something that we'll be deciding that day. We can either, if they're here to speak in person, we can have them speak before a meeting, or I can elaborate more on the comment before a meeting starts or during the agenda item. But I think it's a really good one. And I think it's important to consider as we go forward, sort of what do we do at the beginning of the meeting in regards to public comment? What do we do at the end? How do we fully engage the public in our decision making? So Amy, did you have a recommendation for how you wanted to see it happen, or?
I mean, I could go either way, but I do kind of like the idea of doing it in the beginning. But
Yeah,
I don't have strong feelings.
yeah, we'll think about that. And yeah, I think there's space for both, because I like what Warren said too. If somebody is coming here and attending in person and then they want to comment on a discussion that we had, we want opportunity for that too. So there's probably room for both, and we will work on that. I think it's a great comment. Yeah, Michelle.
As you go back and revisit that conversation, I think one thing that I don't know if the logistics would allow it, but I know that there's often for city councils or planning commissions or that sort of thing, the opportunity to sign up for either non-agenda item where you can basically just give general feedback, and that could be at the end of the meeting, or give comment on an item that's on the agenda. And that might be a helpful way to just divide it up so we can hear people's thoughts. And I think there's also, for a lot of people, it's easier to give verbal comment than written for some folks. So I think I would appreciate the opportunity to hear from folks who have something relevant to the agenda we'll be discussing and making decisions on ahead of time. And then I wonder if there's a way to still create space for non-agenda item comments at the end of the meeting if people would like to. That would mean programming the sign up sheet in such a way that we could delineate, and that may or may not be a barrier, but just another option to think about.
That's a great idea. Yeah. Thanks, Michelle. Any other thoughts? Okay, so for today, we have two folks who would like to give public testimony. We'll start with Charlie Swanson.
Thank you. So I've got comments on a couple things, and both of them were touched on in my written comment. The first one is probably going to be easier, and it relates to long-term care, and then the second one relates to Medicare. So related to long-term supports and services, the Senate Bill 770 that established the task force actually directed the task force to look carefully at long-term care, and it had a number of, but had suggestions, actually had directions on who should be involved in that, like what sort of a committee should be set up to do that, and also the sorts of things that they should be thinking about as they're doing that. The task force did not have the funds or the time to seriously do that. And my strong suggestion is that I would love to see the governance board do that in a manner somewhat like what was directed in Senate Bill 770, because I think those directions might be very useful. It's possible that you would need more funding to do it appropriately. And if so, I think that's one of the things that more funding should be asked for. So I would love it if some board members would look carefully at what Senate Bill 770 said about how to consider whether or not to include long-term supports, such services and supports in the plan, and not do it just as, oh, let's just let Medicaid keep doing it. Because to me, that's a very substantial equity question, and it would be nice if it were very carefully considered. The end result may end up being the same, that that you decide to do the same thing as what the task force suggested, but I would like it to be very carefully considered. Regarding Medicare, related to Bruce's comments about well, you got to include Medicaid too. When most people look at current federal law, they would say states can include Medicaid in the appropriate way. And many people would say it's really questionable whether CMS has the ability to grant the waivers to appropriately include Medicare. And my comment was really about the governance board is going to make recommendations in September of 2026. Waivers do not need to be applied for. It cannot be applied for, at least most of the existing waivers cannot be applied for until after a law is adopted by a state. And so it's going to be at least a couple of years after that before we really have any inclination of whether or not the appropriate waivers will be available. And federal law may well change, and the federal administration may well change. And so I think to try to figure out how likely it is to get a particular waiver at this point, and even by the time you're making your legislative recommendations, I think is not an appropriate task for the governance board. I think that the governance board should decide what is the design of the system that we really want and recommend that. They could also consider the question of, well, suppose we cannot get the waivers, what would we recommend the legislature then do? But that to me is a question that should come later, not in the initial design of the system. In the initial design, it should be, what is it that we want? What will be the most equitable and most cost effective? And let's go ahead and do that. I have one other comment, and this is related to the public engagement. And among the things that I think is going to be the most important to engage the public on is the tax structure. We're going to need lots and lots of public engagement to get people to come up with a notion of what is the most fair system that makes the most sense to enough people in Oregon so that it could be adopted. And so I think that early public engagement on possibilities for a tax structure are going to be pretty important. So
thank you for allowing me to make these comments.
Thank you, Charlie. Appreciate it. And next we have Tom Sinsick.
Oh, thank you very much for this opportunity and your great work and how transparent you all are in the work you're doing from the website to the conversations. It's been really great to observe, and I'm one that likes to comment afterwards, but I completely see the value of the public comments before the meeting. I'd like to tell you a brief story about waste. I made a chiropractic appointment. It was 8 steps to get that appointment. I won't go through the 8 steps versus 1 appointment. 1 step, call the chiropractor and make the appointment. There was a series of things I had to do in order to get that appointment. That is where we talk about where are you resources being used up. This is where resources are being used up. Resources are being used up by the system more than the patients. It's in the administrative waste, and including, that doesn't count my value of my time that even included in that. And it was a lot more to it than I'm talking about now. Congratulations on getting all these applicants. I think hopefully you have a good pool. They'll go forward with that. I love that. Just a reminder, some things you talked about. We have a system in Oregon of private and government providers. So I'm assuming that will be the general. We got county providers, we got VA providers, we got Indian Health Service providers, right, as well as private providers. So I think, but now going to my comment, which I submitted, which was related to the budget, and Charlie Swanson just kind of mentioned that thing. It is really, I was hoping to push an agenda item that this board needs to address the issue of budget as soon as possible, because it's right for the board to speak to what the needs are in order to accomplish the mission. I think you have a good basis, but when the board speaks and says, this is what we need, then those that are advocating out there to make sure this job gets done correctly, and the legislators who are watching this, it becomes easier at least to eventually get that funding. So I think answering that question is essential. Do you have the funding now? Because money has been saved because of the late start. And then sounds like you're trying to get the right people on board. I leave that all up to you, but it's been outlined in there somewhat who those right consultants are. Those consultants are going to be needed for the committees to get them guidance and information. And so I guess that's my push for the moment is let's get the budget on the agenda. Thank you.
Thank you, Tom. We really appreciate it. Any other comments from the board? Okay, we have a closing quote here. I think it's from Judy, is that right?
Yeah, thank you. So this is Amanda Gorman, who says, since the world is round, there is no way to talk away from each other, for even then we are coming back together. Some distances, if allowed to grow, are merely the greatest proximities. And the reason I chose this, not because we're all going away and we'll come back to another committee meeting, but because like poetry does, it challenges our perspective and our assumption of the world. And I think that is at its fundamental core what we're trying to do here for healthcare in Oregon, is challenge the way we've thought about it for a long time and to embrace new ideas and new perspectives for how we can move forward.
Thank you. That was great, Judy. Appreciate it. Would anyone like to volunteer to bring sort of thought? It could be a quote, it could be a poem, it could be an anecdote, it could be just a reflection for the next meeting.
I can. I haven't yet.
Great.
Amy.
Okay. Is there any other business? Great. Then we will adjourn. Thank you all for coming. And thank you for participating virtually. We really appreciate it. Thank you for the tech support, Katie, as always.